Good day. We start with a new series of lessons called Hypertensive Conditions During Pregnancy, Labor and Postnatal. I'm Anna Nolte. And in this course, we are going in this first lesson, we're going to talk about mortality classification, pregnancy-induced hypertension. And then in lesson 2, we will talk about the physiological changes during pregnancy regarding the cardiovascular system and blood pressure. And then we will also talk about the pathophysiology of the hypertensive conditions and specifically preeclampsia. And then in lesson 3, we will talk about preeclampsia and specifically here mild to moderate preeclampsia. And then in lesson 4, we will do serious preeclampsia and eclampsia. Okay, so as I've said in lesson 1, this lesson we're going to talk about maternal mortality regarding hypertension, and we will talk about the classification of the different hypertensive conditions during pregnancy, labor and postnatal, and then we're specifically going to talk about pregnancy-induced hypertension. Now, about the maternal mortality due to hypertension, just to give you an overall picture of maternal mortality. We in South Africa get 3 yearly reports, which we call Saving Mothers reports, and in these reports are full details of the maternal mortality numbers in South Africa, what causes it, and also avoidable factors and different factors that causes it. So if you have time, you can Google Saving Mothers reports and you can read in the different reports what the causes for maternal deaths in South Africa are. And I think it's a very advisable, it gives you a good insight into maybe even your clinical facility and what possible reasons for maternal deaths there are. And it's not only in the public sector that mothers die during childbirth. Now, the maternal mortality rate in 2017 to 2019 was 113.8 per 100,000 live births. That's how we usually indicate the maternal mortality number, the rate per 100,000 deaths. Now, in this 3-year period, non-pregnancy related infections were the cause for the highest number of deaths. And non-pregnancy related infections here specifically refers to HIV, which was the highest cause for maternal deaths during that specific 3 years. It was followed by hypertension. I will show you on a bar graph just now how these all relate. And then third highest cause for maternal deaths were obstetric hemorrhages, which we will discuss in our next series of lectures. And then followed by that are medical and surgical conditions. And here we refer to conditions like, for example, cardiac conditions, diabetes, etc., which is also not 100% directly related to pregnancy as such. Here you can see a bar diagram with all the different causes for maternal deaths, hypertension here, obstetric hemorrhage here, and then here you see non-pregnancy related infection. Now, if you look here, you will see the dark blue is 2017 to 2019, and you see here it's still by far the highest cause for maternal deaths. The reason why there's such a decline, why the other causes more or less stayed stable, you will see there was a very high death rate here, maternal mortality rate here, due to non-pregnancy related infections, and that was in 2008 to 2010. And then gradually it came down to now in 2017. And the biggest reason for that, just for interest's sake, is because of the introduction of medication ARVs during pregnancy for the mothers who are HIV positive, and that has increased the numbers so much. Here you can see hypertension that stayed more or less stable over the years, which is not a good thing. It should have gone down. And you can see hypertension the maternal death caused by hypertension is slightly higher than that by obstetric hemorrhages. So this is the second highest, the reason for the second highest, or the second highest reason for maternal deaths in South Africa, and obstetric hemorrhage is the third highest reason. On this slide, we're going to talk about how to measure blood pressure. And you might think that I'm totally silly to teach you how to measure blood pressure, because I think you're all supposed to know it by now. But in pregnancy and childbirth, it's specifically important for us because of all the physiological changes that happened related to the blood pressure, and also because specifically in serious and severe preeclampsia and eclampsia, it's very important for us to get accurate measurements of the blood pressure to see whether the maternal condition is improving or not. So that is why I spent the whole slide on how to measure blood pressure accurately during pregnancy and labor. First of all, and I think that's general common knowledge, the cuff size should be the correct size. So that, as you can see in this photo, that there's a big overlap between the end of the cuff and the beginning of the cuff so that we get an accurate measurement. So the cuffs should be at least 1.5 times the circumference of the arm. And this is specifically important in obese patients. And specifically in patients where the mid-upper arm circumference is more than 33 centimeters. We should have a larger cuff than the normal size cuff to enable this overlapping to happen properly. Then the position of the patient is very important during pregnancy and labor specifically. We all know that the patient should never lie flat on her back when we measure blood pressure, because it's usually lower then than normally, because specifically when the uterus is big, it pressures on the vena cava inferior and the aorta that's running just above the spine, and that makes that the cardiac output becomes less because the blood flow to the heart is slower now, and that decreases the blood pressure. So the mother must sit or lie on her side with at least a 30-degree lateral tilt. And then the other very important aspect is where the level of the cuff sits regarding the level of the heart. It should be on the level of the heart. It should be more or less on the same level of the heart than the heart. So if the mother is lying down, we should always use the lower arm because the upper arm is above the level of the heart. And when she sits on a chair, and it's always good to have a place where she can lean her arm on, the cuff and the apparatus should also be more or less on the same level. And then it's always good advice to have the mother to rest a little bit before we take the blood pressure. Specifically mothers coming to antenatal clinics or to come just in for a blood pressure measurement or whatever, they might be tired of walking, they might be anxious, they might be nervous because of the strange environment in which they are. So to get the accurate measurement, it's always a good idea to have the mother to rest a little bit. Then we come to different definitions of hypertension during pregnancy specifically, and we say that when the diastolic pressure is above 90 millimeters mercury at 2 occasions, and this is very important, we will come to that just now, about 2 hours apart, or a single diastolic measurement of above 110 millimeters mercury, and the systolic pressure of above 140 millimeters mercury or above 160 millimeters mercury. So in other words, we say a blood pressure of more than 140 over 90 indicates hypertension during pregnancy, or if it's above 160 over 110, it indicates severe hypertension. Now, the reason why it's important here to take it on 2 occasions, at least 2 hours apart, as I've said previously on the previous slide, mothers often are anxious when they are coming for their blood pressures to be measured. specifically if they're coming to the antenatal clinic or when they're coming to the antenatal ward or whatever, and if they're anxious and they're nervous, it's a good idea that if you have measured the blood pressure and it is above 140/90, to just give the mother a good rest, make a cup of tea or coffee and let her lie down, and then 2 hours later you take the blood pressure again. And if it's still above 140/90, we define that as hypertension. Now on this slide, we just have a few aspects that's very important regarding hypertension. The first of all is, as you will see in the next lesson, when we do the physiological changes of the cardiovascular system during pregnancy, we will see that the blood pressure is supposed to decrease during pregnancy and never increase. So we always said that an increase of 30 millimeters mercury systolic or 15 diastolic might also indicate hypertension. Now, we don't use that as an indication of hypertension anymore. As we've said, our definition of hypertension is a blood pressure of 140/90. But we should always be aware of this rise in blood pressure. And this patient becomes just a little bit of a high-risk patient and we should monitor her very carefully for hypertension. Then proteinuria is always very important for us in relation to hypertension, and we will come to that more definitely when we talk about preeclampsia. But proteinuria should not be ignored when there's not hypertension. Proteinuria is always important for us, even in the absence of hypertension, because it might also, as I think most of you know, also be an indication of urinary infection. So we have to make sure that the protein in the urine is not because of urinary infection. Other reason for protein or possible reason for proteinuria in the urine during pregnancy is because, again, physiological changes. We get an increase in vaginal secretions during pregnancy, which, as the patient might urinate, might come in the urine and be responsible for the protein in the urine. So that's why it's always important, if there's protein in the urine, to take a midstream specimen to make sure that what we measure is protein in the urine and not because of the increase in the vaginal secretion. Then another very important aspect regarding hypertension is we always associate hypertension with pregnancy and labor. But very often, the most severe cases of hypertension might happen postpartum. And even if you read the Safe Mother report, you will also see that the highest number of maternal deaths due to hypertension happen during the postpartum period. So what is very important is don't just take the blood pressure for the first 6 hours after the birth of the baby and then ignore it, because we can still get very serious hypertension during the postpartum period. And then just lastly on this slide, a raised systolic pressure is usually the important measurement for us during pregnancy. And a raised systolic pressure, even if the diastolic pressure is still normal is always an indication of hypertension. Now, when we look at the classification of hypertension, we divide all the different hypertensions in different classes. First of all, we get the chronic hypertension. That is a hypertension before 20 weeks of pregnancy. We can also call it the essential hypertension. This is mothers who were hypertensive even before she got pregnant or before 20 weeks pregnancy. You will see 20 weeks is kind of our division here, our marker here for chronic hypertension and gestational and preeclamptic hypertension. And that's basically because of the causes of the hypertension, which we will also come to in the next slides. So if the mother was hypertensive before pregnancy or before 20 weeks of pregnancy, we usually talk about chronic hypertension, and there's usually no proteinuria associated with that. Then, if the mother is hypertensive after 20 weeks of pregnancy and there's still no proteinuria, we call it gestational hypertension or pregnancy-induced hypertension. The correct latest terminology is to talk about gestational hypertension. This is hypertension that's usually between 20 weeks of pregnancy and after the birth of the baby, and the blood pressure usually goes back to normal after the birth of the baby. Then our third group of hypertensions is preeclampsia. Here we have hypertension plus proteinuria or hypertension plus one of these symptoms, low platelet count or increased creatinine level or liver enzymes being elevated or cerebral symptoms, of which headache and visual disturbances are the most important. So we say preeclampsia is hypertension plus proteinuria or one of these. And then we get our fourth category is eclampsia, and that's where preeclampsia goes over to convulsions. The mother gets convulsions, and that's what we call preeclampsia. Then we also get preeclampsia superimposed on chronic hypertension, and that's when these mothers with chronic hypertension develops proteinuria in the protein in the urine or one of these symptoms, and therefore developed preeclampsia. Then we talk about preeclampsia superimposed on chronic hypertension. Now, okay, if we focus specifically on gestational hypertension, or as I've said, we also call it pregnancy-induced hypertension, and this is where hypertension develops without proteinuria after 20 weeks of gestation, without proteinuria or any of the other symptoms that we associate with preeclampsia, namely coagulation problems, liver enzyme problems, creatinine, kidney problems, etc. Now, gestational hypertension is usually fairly normal, but one should never ever ignore hypertension during pregnancy, because it also has adverse pregnancy outcomes, and it very easily also go over to preeclampsia and eclampsia and HELLP syndrome. So under no circumstances should we say, okay, she only has gestational hypertension, there's no proteinuria, and we don't worry about that anymore. And specifically also, this is very important for mothers during labor, not to ignore hypertension. The effect on the fetal heart and fetal compromise is as bad as that of preeclampsia. So gestational hypertension is also always something to take note of. Now, when you take a pregnant, low-risk pregnant mother's blood pressure and it's borderline, it's between 135 or 185 and 139 and 89. So it sits basically just below 140/90. It's always a good idea to just take it again, also after 2 hours, and just make sure that it's below 140/90 and not over it. And then it might be a good idea to ask the mother to come back in 3 to 7 days to just make sure that the blood pressure is still normal. Now, the management of gestational hypertension, it's almost been summarized in this last sentence here. The treatment is similar to that of preeclampsia. We, as I've said previously, are as worried about gestational hypertension as we are about preeclampsia. We usually use alpha-methyl-dopa, of which you know as best as Aldomet, is usually the most common method to treat pregnancy, gestational hypertension with. There are also many other names for pharmacological names for or for methyl-dopa, but that's the medication that's being used most often. But also to just make 100% sure that it's only gestational hypertension and not preeclampsia, it might also be a very good idea to do blood tests and determine the HB, the platelet, and the creatinine counts of this mother as well, to make 100% sure that it's not preeclampsia. And then obviously we have already tested the maternal urine for protein as well. It's, as I've said, any hypertension might have as a bad effect on the fetus as preeclampsia has, because we get cardiovascular changes. We need blood to take oxygen to the fetus. If something goes wrong in this cardiovascular circulation system, the fetus might be compromised. And therefore, it's always good to determine that the fetus is in a good condition. So if the mother goes home, and we will see, as you will see later on, in most cases, in the case of gestational hypertension and also in the case of mild preeclampsia, the mothers are usually being sent home and stay home. So it is very important to teach the mother about fetal movement counts so that she do it regularly and make sure that the fetus stays normal. And then very important, and we will come more later on to the serious signs of preeclampsia. Those are headaches, visual disturbances, epigastric pain, and the decrease in urine is usually a later one. We should educate the mothers on those signs, specifically when they are going home, but also when they are staying in hospital, so that they can immediately report it when they experience any of those signs, and that we can immediately check whether the blood pressure has been increased or not. Just a few words on gestational hypertension during labor and how do we care for these patients. The blood pressure should be assessed hourly in women with mild and moderate hypertension, and then when it gets more severe, every 15 to 30 minutes, and this also depends on how severe the hypertension is. So obviously more often when it becomes more severe. Then I would, in all cases with hypertension, always monitor the fetal heart with a CTG. In the mild cases, it's not necessary to do it continuously with a CTG machine, but I think periodically the fetal heart rate should at least be monitored with the CTG machine as well, to just make 100% sure that it stays normal. Again, I can't emphasize the possible effect of hypertension enough on the fetal heart. I'm saying the possible effect. It's not always a bad effect, but as I've said, there is a possibility that it might cause compromise. Now, the antihypertensive treatment that the mother was on during pregnancy should be continued. So if she was on Aldomet, for example, it should be continued during labor. Now, there's a lot of debate on whether these mothers should receive epidurals or not. Epidurals, as you know, will decrease pain and therefore also anxiety, etc., which might cause an increase in blood pressure. But we also know that during the epidural, we might get a sudden fall in the maternal blood pressure. So that is one absolute thing that we should be taken in very consideration, is the possible hypotension that's being associated with epidural, and therefore we should very cautiously preload the mother and obviously very cautiously monitor blood pressure if an epidural is being given. Then syntocinon is recommended for use for active management of the third stage of labor. I think in most hospitals and in most cases we use syntocinon in any case for the management of the third stage of labor. Syntocinon causes a gradual contraction of the uterus. So what is very important here is after the birth of the baby and the uterus contracts, all the blood that's in the uterus is now being pushed back into the circulation. And in a hypertensive mother, that might be very important. Now, syntocinon, as I'm saying, is causing a gradual contraction, while symptometrin causes a tonic contraction. It causes an immediate contraction, and all the blood flow is immediately pressed back into the mother's circulation. So that's why it's very important in the case of hypertensive mothers never to give symptometrin to them. And then very important, the observation of the maternal blood pressure during the postnatal period, as I've said before. So important. And then we've come to our last slide in this lesson. I hope you enjoyed it, and please complete the quiz so that you can continue to the next lessons.